Hello, so I'm Joel and this is Zoe, and we are going to be talking about the mastoid process of the cranium. So in this presentation we're going to look at the overall structure of the bone and the function that it has. Then we're going to look specifically at the air cells and then the pathophysiology associated with this. So to start off with the structure, so it's part of the temporal bone and it's just posterior to the external acoustic meatus and lateral to the styloid process of the temporal bone. So it's located about the vertebral level C1 of the atlas. And it also forms the posterior wall of the middle ear. And it is actually bigger in males. And the reason that it is bigger in males is because of its function. So it's a site of attachment for the four muscles that you can see there. So it is initially absent in the neonatal skull, but then the pull of sternocleidomastoid, particularly postnatally, means that you get this protuberance. And as we know kind of from MSK, that if there is like a protuberance in a bone, that's usually because it's a site of muscle attachment. And so the reason that it's bigger in males is because sternocleidomastoid tends to be much bigger. So particularly the air cells are of interest. And these are basically just a network of sinus cavities in the mastoid process. Initially, the mastoid process isn't pneumatized at birth, but kind of becomes aerated over the first year of life. And the reason that the air cells are of interest to us is because they can communicate with the middle ear, as we've kind of already heard, via the epitympanic recess. So I'll just kind of talk about the route of communication. So starting from the mastoid air cells, start off with those, and then that connects via the mastoid antrum. And this is just an airspace in the petrous portion of the temporal bone. And then the mastoid antrum connects to the epitympanic recess via the oditis to mastoid antrum. And the epitympanic recess is just located at the superior aspect of the middle ear. So the function of these air cells is kind of, in literature, it's a bit unclear, they're not quite sure, but it's mostly agreed that they equalise air pressure in the middle ear, and they also act as a buffering system or an air reservoir. And all that means, what is relevant is when there's a eustachian tube blockage, that there's kind of a buffering system of air for the middle ear. And they also reduce the weight of the skull, but we're not quite sure whether that's the primary reason or not. Now Zoe's going to talk about the pathophysiology.
So we're only really going to talk about Mastoiditis. So it's a bacterial infection of the mastoid antrum and the air cells. So as Will's already sort of mentioned, it tends to come from a middle ear infection by the oditis. So that's the otitis media. And you can often get a cholesteatoma with it, which is basically like a build-up of cells, and they can become necrotic, and you get like lytic enzymes, and they sort of degrade the middle ear and the mastoid bone. It's most commonly caused by strep pneumoniae, but there are some others there. You can see it there in that picture, so it's like red, tender, swollen behind the ear. If the tympanic membrane's ruptured, you'll get a discharge from it. There's a hearing loss, which is conductive, so as Liam mentioned, with a conductive hearing loss you'll get a negative Redness test, and on Weber's test you'll find that they hear it louder in the affected ear. They also have a fever and a headache. So you can see that the otoscope exam, if you looked at it, if they've got a ruptured tympanic membrane, you'd be able to see that, and you'd also see sort of a redness and a swelling. You can also do a blood test. If it's an infection, you might see raised white blood cell count. You can do an ear culture, so if there's the hole in the tympanic membrane, there would be a discharge which you can collect, or you can do a tympanocentesis to collect some fluid to culture and do a gram stain on. And you can also do a CT scan, which can aid your diagnosis, and you can also look to see if there's any other problems intracranially. In terms of management, it's managed in a hospital, so you give IV antibiotics, broad spectrum, for the first 2 days, and then you give a course of oral antibiotics for a week or two. In terms of surgery, you can do a meningotomy, which you can see in the picture there. You make a small incision in the tympanic membrane, which allows you to drain the fluid, and then you can insert a tube which has helps to keep the middle ear aerated to prevent any further accumulation of fluid. You can also do a mastoidectomy, which is where you remove all of the infected cells, and if you've got that cholesteatoma, you can also remove that there as well. It's got a pretty good prognosis now, but there are some complications. So I've already mentioned the hearing loss. You can also get osteomyelitis, which is an infection of the bone, and that can also travel to the middle cranial fossa. You can also get some cranial nerve palsy, so I've talked there. There's the facial nerve, abducens and trigeminal nerve, and then it can spread intracranially, and you can get abscesses in the brain, or you can get meningitis. And that's everything.